Good morning, everyone. I'm going to be creating some voiceover PowerPoints for you that are going to cover the content from class today. I'm going to break them up into several small chunks and load them on Blackboard for your use. If you have questions or concerns after you have reviewed all of the voiceover PowerPoints, please touch base with me or Mrs. Farrell to discuss them. The first topic that was on our discussion topic for today was schizophrenia, and that's the management of thought disorders. Our objectives from this section of the lecture are to make sure that you guys can distinguish key symptoms of schizophrenia, that you can apply the biopsychosocial theories relevant to schizophrenia. And all that means is that you need to know the theories that come from the biologic domain, the psychological domain, as well as the social domain that help us understand the causes of schizophrenia. And then the last one is to understand the impact that schizophrenia has on the clients. And we want to make sure that you have real clarity about hallucinations, delusions, and the impact of social isolation for clients who have schizophrenia. This table provides an overview, it's from your Boyd textbook, of the different types of spectrum disorders. And historically, schizophrenia was a separate and distinct disorder from schizoaffective disorder or the delusion disorder. That's not the case now. Now they consider them to be on a spectrum, and it's a spectrum of severity and causation. So I wanted you to kind of have this snapshot for you to have a quick reference point of, you know, what are the, how do they move across the spectrum? I want you to be thinking about the clinical course of schizophrenia. When we think about a client who has been diagnosed with schizophrenia, typically in the early diagnostic stage, people will say when they were a child or early adolescents, they were just different. There was something quirky about them. That's considered the prodromal period. That's when there's a symptom, there's a sense that something is different, but that there's no acute symptoms. Often they'll describe the person as being nervous or overly focused on things, maybe having depression or some moodiness. The big thing that normally is noticed is social withdrawal. For some reason, this person just seems a little bit different and struggles in the social realm and engagement in their life. That prodromal period ends when acute illness begins. The acute illness was when there's full-blown symptomology. It may be subtle or it may be acute, and psychosis is normally seen in this period of acute illness. Stabilization is when there's intense treatment with lessening signs and symptoms. So stabilization is when there is an active effort to manage the symptoms so that the person begins to have some improvement in the symptoms. So you should see some progression in their wellness. The symptoms are still present, but there's some positive response to the treatment that's being offered. And then you move into the maintenance and the recovery phase. This is when the patient is at their most optimum level of functioning. I want to remind you that the maintenance and recovery period does not bring the person back to their baseline. Very, very rarely is someone that's diagnosed with any kind of psychosis or psychotic disorder, are they going to come back to their baseline? There's a few exceptions, like the brief psychotic episodes that are brought on by stress, some substance-induced psychosis can. But when we think about schizophrenia and schizoaffective disorder, the goal in maintenance and recovery is really to get them at the best that they're going to be. And that's normally through really good medication management and good case management to offer support and a safety network for that person. And then the last phase is a relapse phase. We often don't want to talk about the relapse phase because it's pretty distressing when you realize that the vast majority of people who are on this psychosis spectrum are really going to experience some kind of relapse throughout their course of care. So relapse, really, what we know about relapse is that most of the causes for relapse are medication non-compliance. Because schizophrenia and the other majority of psychotic disorders are biological in domain, we need a biologic intervention. So when the clients who've been diagnosed with schizophrenia relapse, it's because they have stopped taking their medication, and that's almost always the cause of it. So medication compliance is super, super important when we think about how we intervene on the clinical course of a client who's been diagnosed with some sort of psychosis or psychotic disorder. When you have someone who is presenting with concerning symptoms, we break them into three groups of diagnostic criteria: your positive symptoms, your negative symptoms, and neurocognitive impairment. We want you to be able to differentiate between positive, negative, and neurocognitive impairment so that you can recognize what you're seeing when you are engaging with clients who have these kinds of disorders. When we think about positive symptoms, I want you to be thinking about that as the symptoms that are added to someone, something that's new, and it's not preferred. We refer to the positive symptoms as either delusions or hallucinations. So think about your normal brain functioning and the addition of delusions, which are ideas that are abnormal, or hallucinations, which are sensory perceptions that are also abnormal. So positive symptoms are things that are added into your perceptions that alter the way you see the world. When we think about delusions, there are multiple types of delusions. There are delusions of idea of reference. Ideas of reference are when things are misconstrued or misinterpreted events to have significant personal relevance. So this is someone who has a belief that that something that is occurring in their world has specific meaning to them. So this could be that they believe that at 6 o'clock the news anchor is providing news information specifically to them to convey a secret message. They believe that that message is specifically for them. Ideas of grandeur. These are delusions that has the person that believes that they have exceptional powers or wealth or skill or influence, or that they have a special destiny. So ideas of grandeur are when they believe that they are highly exceptional, and we think kind of superpower-ish. Nihilistic are the beliefs that one is dead or a calamity is pending. That means that they are constantly afraid that that there is pending death in front of them, that everything that occurs to them could cause their death, or they actually believe that they have died, and they firmly believe this. The delusion of persecution is the belief that one person is being watched, ridiculed, harmed, or plotted against. So when we think about persecution, this is the person that believes that every time they go into the grocery store, that the scanner that opens the doors, that scanner actually is intending to send radioactive waves into their brain and disrupt their thinking. So they'll do protective mechanisms to prevent themselves from being harmed from that action or that event. And then the last one is a somatic delusion. And this is the belief about abnormalities in body function or structure. So these are the people that are convinced that a change in their body is significant and often life-threatening. So these are people that are highly somatic and that they're delusional in their perspectives of what's going on in their body. I want you to be familiar with these different types of delusions and to understand that that falls into the bucket of the positive symptoms. The additional positive symptom are hallucinations, and hallucinations are perceptual experiences that occur without actual external sensory stimuli. Hearing is the most common hallucination, but all 5 of your senses can be impacted by a hallucination. So if you think about someone who has a diagnosis of schizophrenia, they have the positive symptoms of delusions or hallucinations. Then they can also have a combination of negative symptoms. And negative symptoms are the classification of symptoms that actually take away from the person's wellness or their life. So they're removing things. So when we think about negative symptoms, there are several what we call cardinal symptoms that fall into the bucket of negative symptoms. We have affective changes. So these folks have flat affect. They show little or no emotion, and this is especially occurs when there's something significant going on that may impact someone a regular person, they don't perceive that loss at all. They don't get upset. They're just very flat. Avolition is a lack of drive or daily activities. And when we look at avolition as part of the negative symptom group, we also see this in the area of hygiene. These folks lack complete drive to do the regular daily life stuff like hygiene or laundry or housekeeping. They have absolutely no drive to do that. Anhedonia, which the other word for that is apathy. This prevents a person from enjoying activities. We see anhedonia or apathy in depressed clients as well. So you could see that term used when we talk about depression. Specific to a client who has schizophrenia, when we think about the negative symptom of anhedonia, we're talking about someone who has absolutely no enjoyment in the things they used to enjoy. If they had, earlier in their life, really enjoyed bicycling, all of a sudden they have absolutely no interest in it. And we think about those, the anhedonic responses as something that is traditionally something they enjoyed, but now they do not. Asociality, which is just a way of saying that the person lacks interest in social contact. It is made worse by their behavior, especially if they have positive symptoms. The asociality is their complete withdrawal from the world around them. It can be because they have been mistreated and they kind of close in on themselves to avoid contact with other people. They could also have asociality because they think something bad is going to happen to them if they're engaged in the world around them, so they begin to fold inward. And again, when we think about those really, really early prodromal symptoms, the asociality is one of the ones that shows up on the radar earliest. The next one is alogia. Alogia is a type of expressive aphasia. It's limited speech and difficulty saying anything new or carrying on a conversation. So these are folks that really seem to struggle finding their words when you're speaking to them and engaging in them. And the last one is anergia. Anergia is the lack of energy. So if you think of someone who has a combination of those positive symptoms of delusions or hallucinations, you add these negative symptoms of affective changes or avolition, anhedonia, asociality, alogia, and energy. All of those things are going to really cause this person to socially isolate. You have all these things that are frightening you, and then you have all of these things that are taking away your joy, taking away your energy, taking away your excitement for things that used to matter to you. You begin to fold inward and you become really isolative, where you kind of become a person into your own world. Adding that third diagnostic criteria of neurocognitive impairment complicates things even more. Neurocognitive impairment for some clients can impact memory. It can impact their level of vigilance about what's going on around them. They can be super sensitive to things or completely unattentive to things. They can have difficulty with verbal fluency and executive functions like higher order thinking. The neurocognitive impairment varies widely across folks who have diagnosed with schizophrenia. There are some that maintain absolute cognition. They're clear as a bell. They are alert oriented to person, time, place, and event, and they are absolutely certain that the voice they are hearing is God, and that voice is telling them to do a specific act. And if they don't do that specific act, something bad will happen. When you see someone who has schizophrenia and you see them in the midst of their active disease, it is really disturbing to realize that this person honestly believes what their delusions are telling them, and they honestly, their perception of hearing or seeing things that aren't there is very real to them. The end result of all of these events for these clients is that they become very fearful and they begin to isolate. So I want you to be thinking in a perspective of compassion when we look at these folks that are really struggling. And I want you to be able to kind of be able to understand what positive and negative symptoms and then the neurocognitive impairment potential for these clients looks like. The definition of psychosis is a state in which a person experiences symptoms including hallucinations, delusions, and disorganized thoughts, speech, or behavior. So psychosis is a hallmark sign of someone who has schizophrenia. So I want you to know that definition. When we're looking at symptoms of someone who has disorganized symptoms in their schizophrenia, these are characterized as disorganized thinking and speech and disorganized behavior. Thinking and speech are really complex, and we have spent decades and decades trying to understand how to describe the abnormal behaviors and thinking and speech that we see with our clients. These are the vast majority of ways we describe patients who have disorganized thinking and speech. I have in the notes section of this lecture, all of these vocabulary words are defined for you in the notes section, so I'm not going to take the time to read those to you here. Just know that if you print off this slide, that it's going to have all of these defined for you. I want you to pay special attention to just a few that I'm going to point out. Concrete thinking is the lack of abstract in thinking, inability to understand punchlines, metaphors, and analogies. Concrete thinking can be one of those common things that we see with folks who have schizophrenia and their thinking and speech has become disorganized. They really do not understand metaphors or abstract thinking. They are very black and white thinkers, and that makes it really hard to kind of communicate, because a lot of our language is nonverbal and casual and not very precise. And folks who are dealing with this concrete thinking, they have a very difficult time understanding exactly what you mean when you're speaking. So when you're dealing with folks who have schizophrenia, you want to be very, very clear. You want to be very precise in your language. You want to avoid sarcasm or slang terms or things that require the person to make an inference from something that you're saying. Another one I want to point out is the concept of flight of ideas. Flight of ideas is a topic of conversation changing repeatedly and rapidly, generally after just one sentence or phrase. This is one of those things that once you see it, you've seen it, and you know that it is. The flight of ideas literally is a bounce of topic to topic to topic. And while there's often a thread that kind of makes sense, sometimes it's a sound, sometimes it's a word, you can tell that the ideas are very loosely associated, and you really can't connect a cogent thought. So I want you to be aware of that one. And then the loose association is often caught up with the flight of ideas, which is the absence of normal connectedness of thoughts, ideas, and topics. And there's a sudden shift. So when we see flight of ideas, often we also see the looseness of association, and those two are commonly seen together. I want to jump over to pressured speech. Pressured speech is speaking as if the words are being forced out, and this is an enunciation of how the words are sounded. They're very choppy, they're very pronounced. It's almost like they're hitting on every single syllable, and it's a struggle to get the words out. Again, pressured speech is something that's very common for clients who have schizophrenia. And if you think about those negative symptoms of schizophrenia, think about alogia, which was one of our negative symptoms of the limited speech and difficulty saying anything new or carrying on a conversation. So you have someone who's already struggling to clear their mind and to get their thoughts out, and sometimes that presents itself with pressured speech of just every single word is just, it's almost like it's being forced out of their mouth. Referential thinking is the belief that a neutral stimuli has special meaning to the individual, such as a TV commentator speaking directly to the individual. We often see referential thinking with delusions. So kind of connect those two thoughts together. And then the last one is word salad. And word salad, flight of ideas, and a loose association have some tangential relationships. The word salad is a string of words that are not connected in any way. So you can have someone who is trying to get their thoughts out, and what they're saying to you is Apple Blue Drive, and you're standing there, have absolutely no idea what those three words have to do with anything, and they repeat them or they shift them to, bridge, car, park, stop, drive, mom, and they have absolutely no meaning to you. To that person, they have some meaning to them. So they may become very frustrated in that process of communicating their ideas because they can't get the words out. So I want you to think about these lists and think about, what does this look like from a client perspective? How frustrating this must be to be inside your own mind and have some level of awareness that your thinking is unclear and that people aren't understanding you. And again, because it's more and more difficult for the thinking and the speech to be clear, people withdraw from people that can't communicate clearly. And this further isolates the client who has schizophrenia. So the disorganized symptoms in the behavior bucket, these are the 8 that I want you to be aware of. Most of them are very straightforward. There's 3 I want to point out and make sure you understand. Catatonic excitement is a hyperactivity characterized by purposeless activity. Abnormal movement, such as grimacing or posturing. So catatonic excitement is a hyperactivity characterized by purposeless activity and abnormal movement. It is often seen as grimacing or posturing. Echopraxia is the involuntary imitation of another person's movement and gestures. And then waxy flexibility is the posture held in odd or unusual fixed positions for extended periods of time. The catatonic excitement, echopraxia, and the waxy flexibility are not commonly seen, but when you see them, you are very aware of what you're seeing. It is very clear that these body movements are very abnormal and that they line up under that disorganized behavior for clients who have schizophrenia. So I do want you to be kind of familiar when we think about speech and thinking versus actual behavior. Just a quick comment on aggression and agitation. When we see folks who have schizophrenia and have psychosis that have aggression and agitation, the vast majority of folks who are aggressive or agitated, it is from fear and anxiety. They truly believe something bad is getting ready to happen to them. They truly believe that if something occurs, that they're going to need to protect themselves. The agitation is often out of frustration. It's out of constant stimuli of a voice being in your ear, or you seeing things that are frightening, or people not being able to understand you, or people rejecting you. That agitation is real, and it's often caused by what's going on inside their head, as well as what's going on with them socially. So when we see someone who is behaving aggressive and they're responding to external stimuli, our first go-to needs to be to validate that their feelings are real and offer safety and comfort and validation that we see them, that we hear them, that we're there to keep them safe, and that we're there to help resolve what's making them upset. Do not dismiss it as someone that they're just angry, that there's no rationale to what is causing them to be angry or to be hostile or to be aggressive. We have to remember that there's a significant change in what's going on in their brain chemistry that's causing a lot of their feelings as well as their emotions. This movie, I showed you the beginning of. I want to take a few minutes and just let you watch this and listen to it for a moment.
Well, I'm flattered. He's a good-looking guy.
What's wrong? It's legal jargon.
It says that I have schizophrenic mind. I do not.
It doesn't mean anything.
Schizophrenic mind.
That's not what I think. Nathaniel, they try to put people in a...
I'm not going anywhere.
And the good news is it has nothing to do with it.
I will go where you say go. I go where I want to go. Okay. You don't put me away, Mr. Lopez. You don't put me away.
Okay.
You don't put me away.
I'm not...
Yes,
No. Yes, you don't have to go
yes, you
to
are.
court. You don't have to go anywhere. Jennifer will take care of it.
My sister's not coming near me. She's not coming near me. She's not coming near me.
Okay.
She says she's not coming. I said
right.
she's not coming. She's not coming.
Said, Nathaniel?
You said... Listen, I don't have any more. I don't have any more. Nathaniel, I'm sick of being Nathaniel, and you're Mr. Lopez. Okay, I'm not your slave. I'm not your boy. I'm not Mr. Carl Sanders.
No, I'm sorry.
I'm not Mr.
I'm sorry.
I'm a man. I can take care of myself. I can take care of myself, Mr. Lopez. I don't need you. I don't need the city. I despise the city, and I despise you. If I ever see you again, I'll cut you over and gut you like a fish. Because I'm Nathaniel, and the bears too. Mr. Mr. Nathaniel, the bears during the ITX. Thank you.
As you watch that clip, I want you to really think about first, how did it make you feel? How did it feel seeing two people that were engaged in a pretty social relationship, talking and chatting and getting along, and all of a sudden, Nathaniel's perception of what was going on between them altered very quickly. His belief that that the legal papers he was reading said, they had a schizophrenic mind, and how quickly he escalated into being aggressive and threatening to his friend. I want you to look at this video and then maybe look at it a few times. Look for the thinking and the speech alterations. There was a really great example of the flight of ideas and the loose association at the very end when he was talking about tying the word city and then the word fish together. Spend some time thinking about this. I think this clip does a really good job of giving you some of those abnormal thinking and speech patterns, as well as those delusions of persecution. When we think about epidemiology, risk factors, we know genetic and environment are a piece of them. We know that very often the average onset of this disease is late adolescence or early adulthood. Folks, that doesn't mean that that's the only time it can happen. We have children who begin to display some of those prodromal active illness symptoms in their childhood, and then we have some folks that are in their adulthood that have onset of schizophrenia as well. We say the average is adolescence to early adulthood, but know that there's some outliers. The only thing that I think from an epidemiological standpoint is that we know that having a first degree biological relative poses a significant threat. What we do know is that genetics and biology play a predominant role in the onset of schizophrenia, that it is something that changes in your brain chemistry as well as your brain structure that predisposes folks to develop schizophrenia. When we think about comorbidity with clients who have been diagnosed with schizophrenia, we often see them with substance abuse and depression, diabetes, and disorders related to water balance. When we address substance abuse issues with folks that have schizophrenia, the substance abuse is almost always an early onset use to control hallucinations, occasionally delusions, but normally this is someone that is trying to manage the things that nobody else sees and hears, and they are trying to manage the fear and the anxiety it creates by self-medicating using substance abuse. It is not common to see lifelong patterns of addiction in folks who have schizophrenia because they have found that illegal drugs manage their positive symptoms better than many pharmaceuticals do. And that is an unfortunate statement of how our pharmaceutical science is in the present day, but that's the reality. They have found more relief from marijuana and other illegal substances. Alcohol and marijuana tend to be kind of those first ones that they jump to, but then become more and more addicted to other things as their disease progresses. Diabetes is another comorbid condition, and that is almost always related to excessive weight gain. Lots of these medications that we'll talk about in a few minutes cause folks to get diabetes, and then they develop diabetes type 2. Disordered water balance, I want to mention here, water intoxication is characteristic by abnormally high water intake, and it's followed by a rapid drop of your serum sodium levels. It is common for folks who have schizophrenia, who have lots of polypharmacy going on. They are thirsty all the time, and they drink and drink and drink to fix their dry mouth, to fix their sense of being dehydrated, and they actually wind up having water intoxication. So it's a significant at risk when you have patients who are taking antipsychotic medications. So we want to keep an eye on their sodium levels. It is common enough that we say, we can see it between, about 6% of folks who have schizophrenia and are on psychotropic medications that they're going to experience this. So we do want to watch their sodium levels. Signs and symptoms of hyponatremia, which is the result of water intoxication or too much water, it produces muscle twitching, irritability, and puts the patient at risk for seizures or coma. So you have folks that are on psychotropic medications. They're overhydrating to manage their sense of dehydration, their dry mouth, and then they wind up becoming hyponatremic, which makes them have muscle twitching, irritability, and could potentially cause seizures and coma, which many of their psychotropic medications do. So you wind up with this crazy cycle for a client who's taking medication to feel better, but then it gives them a side effect of dry mouth and a sense of dryness. So they overhydrate and they actually wind up with the symptoms, the side effects of medication appearing to be from the medication when it's actually from water. So we need to watch water use with clients who have schizophrenia very closely. When we think about etiology, this goes back to biological theories. I want you to know that dopamine is the key neurotransmitter that's involved with schizophrenia. I want you to be aware that the medications, the vast majority of them, are targeting the dopamine pathways, and that targeting of the dopamine pathways is what is intended to address the positive and negative symptoms of schizophrenia. The other neurotransmitter that's involved here on the last one is acetylcholine, and acetylcholine has a similar receptor site to dopamine, so it's almost being impacted incidentally. It's not actually the targeted receptor, but acetylcholine gets pulled in when dopamine is being intervened upon with medication. So I want you to know that. I also want you to know that the biologic underpinning of schizophrenia is the predominant thinking for what causes schizophrenia in our population. And this slide basically tells you that it's psychosocial theories. There's no acceptable psychosocial theories. We know that psychosocial engagement and the support from a psychosocial perspective can increase the severity of symptoms or the perceived severity of symptoms. It can impact how quickly someone responds to therapy, because the level of psychosocial support helps that person be successful, helps that person manage the need for social engagement and wellness. What we know is that there's really no known psychosocial cause for schizophrenia. You can't traumatize someone or neglect someone into having schizophrenia. It really is an organic issue. And that's an important distinction. This is really something that just happens. And when it just happens, there's such a huge impact on this person's psychosocial domain from their biological domain that it is really, really a tough disease to manage for the client who's diagnosed, but also for the family, loved ones in the community that have been, walking alongside this person their whole life, and all of a sudden they're not the person they've always known, and they've shifted. So this becomes really a family systems issue. It's important for us when we think about a key to treatment for people who are living with schizophrenia is an interdisciplinary treatment approach. We know that pharmacological management is a priority intervention with these folks. We also know that the psychosocial interventions are really designed to support the person who is dealing with the diagnosis as well as the family. So the psychosocial support are really creating a safety network or a support system for the family as well as the client while the client recovers. Priority issues in care are suicide assessments and aggression and safety for the patient, staff, and others, and antipsychotic medications. We want these folks to be safe, and we will see that suicide rates for people who are living with schizophrenia tend to happen during their, not their active disease, because normally they are acutely mentally ill. We normally are going to see that when they are in the stabilization and the maintenance and recovery period. And the stabilization and the maintenance recovery period is when they begin to get a little bit better, when they begin to start gaining a little bit of insight and their judgment starts to get some clarity. And they may have moments of high levels of awareness of how bad things are and how hopeless they feel. And that hopelessness is what places them at high risk for suicidal ideation. So we want you to be thinking about, just because they're psychotic doesn't mean that they don't have moments of clarity and moments of hopelessness, of this is never going to get better. And with every relapse, that hopelessness increases. As I said before, when we look at aggression from a patient safety standpoint, as well as the safety of others, whether they're care providers, mom, dad, or spouses, or if they're in a hospital setting, we have to be very mindful that these clients are very overwhelmed with stimuli, that their perceptions are often distorted, and that the aggression and the risk of agitation or harming someone very often comes from a place of being afraid, of being of not perceiving things correctly and feeling afraid that something bad is going to happen to them. So we need to be sensitive to giving them a feeling that they're in a safe place and that they're not feeling overwhelmed with what's going on, and that we're present with them when they are becoming more and more agitated, that we remind them that they're in a safe place and that they're going to be kept safe, and that that what they're experiencing is real to them, and that you're not going to leave them alone, that you're not going to let something bad happen to them. We really want to affirm that sense of safety and that someone is with them. The antipsychotic medications are a priority because they are a complicated administration, and then the care of monitoring someone on an antipsychotic medication is pretty complex. So we want to make sure that that's also a priority care. So we want you to be thinking about this. We're going to wrap up this part one of this overview of schizophrenia and the introduction of psychotic disorders. The next video is going to be about how we manage those disorders from a nursing standpoint.